Thanks very much. A great end to the presentations, Chris. I've been told that sadly we have to miss coffee. Apologies. We're going to go straight through, but we're going to shorten the questions to 10 minutes now, and then I think go straight into the wrap up for the day. We'll probably be a little bit ahead of time, but you're going to miss coffee. I hope that's all right with everybody. So some great presentations. Questions?
Yes, Raoul Huseman, University of Michigan. Chris, a question. On the police arrest data, isn't an alternative explanation that the spouse doesn't call the police again because she doesn't want her husband to be arrested?
That is, so the effects that we talked about right now were actually from victim interviews, from 6-month and 12-month follow-ups, not from the official data.
Okay.
In fact, the official data does not show it shows a 10% reduction, but doesn't meet the same standard as the 25%. Right. So the fact is that's the victims telling the interviewers that there is a decrease in the frequency of violence. I think the other point to point out is that probably at least half of the time, the victim is not the one that calls the police. So even in our studies, the experiments, they were someone else that called the police. So there are other ways to pick up, at least half the time, someone else is intervening and calling.
Can I ask one follow-up question? You didn't touch on this data, but I've heard that there is a relation, an inverse relation between crowding and intimate partner violence. That actually, unlike many other activities, when housing is more crowded, there's less reports of intimate partner violence. Can you comment on that?
Public housing context?
Yeah.
Actually, the public housing context is a little bit difficult for us to distinguish because for a long time we thought there was a lot of domestic violence in public housing, only to find out that when you use call for service data or police data, it all gets registered to the same address. So just trying to distinguish the actual rates in public housing versus non has been difficult because of the fact that, especially if you rely on police data, it's co-founded by the fact that many public housing places, until very recently when they gave us for the specific GPS address, it was all one address. So you can, in fact, the initial studies done in the 70s talked about the reduction, and that was somewhat of an artifact of the fact that they were all to one address.
Yes, thank you very much, panel. Mark, I had a question for you. You brought up elder abuse a couple of times in your slides, and I sense from your voice the sense of disbelief, as well as on the positive of this data. I wanted to get your perspective as to why you think that is the case, that the lack of attention to elder abuse, and through the lens and the work that you do.
I think there's a number of elements. Youth issues automatically get more attention. I think elder abuse has been well hidden. Some of it's institutionalized, so it's uncovering it has been more difficult. I think one of the issues which perhaps I'm not sure how much of a focus it's had, but the outcomes are more difficult as well, because there is often inevitably a long-term deterioration just because of the stage of life in an individual. So I think that's sometimes something which inhibits people looking at that particular area. It also disguises issues. Again, it means that there's not such a public understanding and visibility sometimes around that particular area. But certainly some of the things which have happened recently, I can think of some in the UK in particular, have exposed very high levels of issues around this. With many other areas, we're starting to get epidemiology around it, but very little in terms of interventions.
Well, thanks, and my thanks to the panel. A couple of questions for Michael. First, are you now convinced that suicide doesn't always come last? You came third in this panel. I want you to be convinced and affected by that.
It's a random event, you know, not planned.
Not random, but unplanned. I have another question for you. In the U.S., we have suffered some mass shootings, increasing over the past year, ending in Newtown, the mass massacre of young people. In many of these, people have pointed to the role of suicide in the shooter, that the shooter was either planning to or actually successful in committing suicide. This happens as well in suicide murders, suicide homicides, often in the setting of intimate partner violence. But that,
or elders, that's quite common in Florida, for example.
but the role of suicide in these homicide suicides has been pointed out. Does it seem to you that that might be an intervention area, that better prevention plans for suicide or detection of possibly suicidal people, or decreasing access to whether it's pesticides or guns, might be a way to intervene in these?
That's obviously a complicated issue and hot topic in China as well as it is in the U.S. And it's in terms of there's been stuff in the New York Times recently, and China's actually just published its national mental health policy. And it's the balance between care and control of the mentally ill. How much freedom do you give them to buy their own guns, to people who are seriously ill but not immediately violent? Can you enforce hospitalization? And that's an issue that will be revisited now with the new initiatives here in the United States. And China has been criticized because of its rather heavy-handed approach to people who are seriously mentally ill. But clearly we need to find somewhere in the middle. So I think that, because it's not, well, my reading, again, I don't have this data in the United States, my reading is that a substantial proportion do have a significant mental illness. It's not the impulsive element that I'm talking about in China. A substantial proportion of the suicide murders are committed by people who have an active mental illness at the time that's not being treated. And so how much are we willing to restrict the freedoms of the mentally ill in order to protect the community? And that's a sensitive issue both in China and the United States. And there's no easy solution. But certainly America has moved many would suggest that America has moved too far on the pendulum of allowing people, for example, who get into hospital, they can refuse treatment, they can be forced to get in hospital, but they can refuse drug treatment in some states. And that doesn't make sense in terms of mental health. And so finding that middle ground is where we need to do work. And I guess there's research questions that could be asked, but it's actually the community's comfort with restricting freedoms of people with mental illness is where I think most of the decisions will be made.
Yeah. Okay. That was a fascinating set of presentations, and thank you. But I have a couple. I just would like to ask Harriet to talk to a couple of things. One is in Chris's presentation, he spoke to criminal justice data within the criminal justice system with regards to IPV. You didn't really talk about that much in your presentation. How much does that have to do with reduction in child maltreatment? Similarly, in terms of communication campaigns, those large-scale campaigns that we see in every country in the world, but there's a lot of investment in that in the global south, and I'm wondering how much evidence there is for the impact of that work.
So great questions. And first of all, I think that even if people think of intimate partner violence as something separate from child maltreatment, so I was presenting it as a type of child maltreatment, but if you look at the overlap, it's estimated, that it's about 60 to 75%. So what we don't know, because we don't know a lot about preventing intimate partner violence, and by the way, dating violence wasn't included in my review, and I didn't go into detail because, of course, Chris was covering IPV in general. But so we don't know a lot about how to prevent intimate partner violence, but I would say that this is an example where we need to stop thinking about these types of violence as silos and think about how interventions can focus on prevention of more than just one. So to give you an example, another disclosure coming, but I mentioned some work that I'm doing with the NFP. We're actually doing, I'm leading a cluster-based randomized trial in the US. It's all being done in the US, funded by CDC, even though I'm Canadian, but I was born in the US. So anyway, what we're looking at is whether this enhanced model of intimate partner violence prevention embedded in a program that prevents child maltreatment can actually do both. There is evidence from, you saw a slide from Mark referring to John Eckenrode's work showing that in the NFP, when there are high rates of intimate partner violence in the home, the benefits on reduction of child maltreatment wash out. So that's taking it in the other direction. But in answer to your first question, we don't have good information about that. In answer to your second question about these various, health promotion approaches, I mean, I think we need to study that. In Canada, the Public Health Agency of Canada really emphasizes health promotion. Well, based on what evidence? I mean, there are ways of studying it. And Daniel isn't here at the moment, but again, hard to do with a randomized trial, but there are other kinds of designs that can help us study this. And I think we need to take what we've learned from things like reducing traffic injuries and apply it to the violence prevention work, but not just assume that these messages that we get out there work. It's too important just to go on assumptions. So thank you for asking the questions.
Hi, I'm Ellen Schmidt from the Education Development Center, and my question is for Michael. I did a little work in Taiwan, and one of the things that came up there was that there were a lot of suicides occurring in the homes of individuals who had lost their jobs, and they would take out the entire family with carbon monoxide. Did you, because they were losing face from losing their jobs and things like that, did you run across that in your research?
The carbon monoxide story is very interesting. It started about a decade ago when there was a large publication of carbon monoxide poisoning as a method of suicide in Hong Kong. It was front page news, and before that you saw no carbon monoxide poisoning. Carbon monoxide is a very easy way. You get a burner and you burn some charcoal and you cover your window with plastic and you die easy. It doesn't damage the body in any way, so it's a pleasant way to go. And it was publicized widely, and now it's the second most common method in Hong Kong, and I think the third most common method in Taiwan. It hasn't really infiltrated into the mainland very much other than little Macau and the southern part of China. But it shows how methods can change over time and how the media affects the use of methods. It's really quite dramatic there. That there was none at all, and then there was a high public case, front page showed the exact methods, described it, and then all of a sudden it became a primary method of suicide. The question is, are these new suicides that are happening? Are there people suiciding using this convenient method who previously wouldn't have suicided? And there's some data by Paul Yip, my colleague in Hong Kong, who suggests that in fact these are new suicides, people who are now, because of the easy access and the knowledge about this method, are suiciding who previously probably would not have. So we're getting people with lower intent. The family suicide, that certainly happens. It's relatively uncommon in terms of the total numbers.
Oh, right here. Oh, okay, you'll go.
Hi, I'm Julia da Silva with the American Psychological Association. A question for Harriet. Let me see if I got it correctly, what you said. And some of us were talking at lunchtime about how difficult it is to implement evidence-based. And from your presentation is there is little evidence. In many programs that, we all know a lot about, Triple P or Safe Care or NFP, you are saying that we need replication. They are promising. We need replication. So my question is, we are, my association is in the business of promoting evidence-based practices, And so we are doing a big push in terms of having, mental health professionals using what we have evidence for in all sorts of kind of interventions. Not just violence prevention, but therapy. My my question is, since you're saying, for instance, for the area of child maltreatment and all the areas, we don't have a perfect evidence for those interventions. I wanted to say about what conversation I was having with a lot of people from here. Okay, how can we have like a continuing in terms of evidence? Because it's hard to implement, it's expensive to implement, there is resistance to implementation, not funding, and fidelity is even more complicated for us doing programmatic interventions. So then you come in and say, well, there is not that much intervention, evidence. We need more, we need blah, blah, blah. So where are we in this conversation? Since the real world is very difficult for implementation on evidence base. At the same time, you're saying, well, hey, we don't have that much. So.
Yeah, great question. And I think I can give you a perspective because I actually work as a pediatrician and psychiatrist on the front line seeing families where there's family violence. So that helps me with the researcher part of what I do because we can't just, do nothing. But what I think we have to do is we have to, first of all, let's be honest with each other about the evidence. Researchers, it's not just researchers and policymakers, it's researchers and clinicians and stakeholders. Let's all be upfront about what the evidence is. And then when, for example, I'll use provinces in the case of Canada as an example. So we have home visiting programs throughout Canada. But we actually don't know if they do more good than harm, okay? Yes. But what we're trying to do is actually, so I'll give you the example of British Columbia. We got the government to agree that the nurse-family partnership should be evaluated in British Columbia. So they would have been happy just to implement it, but we said, you don't know if the benefits that exist in the US translate into the Canadian situation, especially with the difference in healthcare. So they said, okay, we'll fund a randomized trial. So we're bringing it into it's going to be a province-wide study, and it will be evaluating the NFP compared to usual care. So there's an example where, again, we are not just, standing back and saying we can't do anything, but a number of us have been advocating for the research to happen within that context. Now, I appreciate it's really expensive. Full stop. But think about the expense of not doing anything, and think about all the money that goes into interventions where we don't know if they work, and in fact they may do harm. And this is my point. I know the U.S. is going down this road, and it came out yesterday in Annals about IPV screening. There was one trial of ours that came from Canada, an excellent trial that was published in JAMA, funded by CDC, showing no effects on violence reduction, no effects on health outcomes, and IPV screening is being implemented across this country. Think about the dollars. Think about the dollars from that, and we're talking about opportunity costs that could go into intervention research.
I've got 3 questions lined up, and I think that may be all we can. Can I just have a show of hands of other people? I've got Jim, Evelyn, and Peter. So who else? So it's quite a few. Do you want me to run through, try and take as many as we can, or should we? Okay, so just the hands up now, please. I'll try.
4 people.
Okay, right. So, Jim.
Very quick. One of the gaps in our review here was teen dating violence. It sort of fell through the cracks. And I know of 3 random controlled trials that suggest that school-based teen dating violence interventions are effective. So I wanted to point that out. And very important, could be a precursor to IPV later in life and adulthood, and is an important part of the IPV and youth violence spectrum. So I just wanted to point that out.
Evelyn Tomaszewski, National Association of Social Workers. Maybe we can't prevent, but can we assess? I'm kind of a global question in terms of assessing for suicide or mental health or depression. We've talked about abuse and exploitation. I'm a believer that education is a foundation for prevention. And I'm wondering, as we look at in the gaps in knowledge, I think was one of the objectives of this panel, what are the gaps in knowledge that we have about mental health and mental wellness in terms of indicating either abusive behavior or low self-esteem? I'm thinking about the impact of discrimination, of bullying, of on a person's life and wellness, and also that seems to be that place matters, where we live, the families that we're in. So, but I'm really interested in this idea of mental health and wellness, that we just kind of have put it out there as something that we really can't address, and I don't think that's really what was meant by anybody on the panel. So, gaps, how we might bring that into the discussion.
For me, the biggest gap is the adaptation to other settings in other countries. You know, I don't see people putting a lot of energy into that. They sort of try to use it, but there's no systematic way of doing that. And I think that's where most of the suicides and violence are happening in the developing countries. And there's not much resources for kind of systematically making that transition. And I think it relates to mental health and well-being because that varies in different social, cultural contexts as well.
Yeah, and I'd also like to address that because in my presentation I talked a lot about competence, and behind that is mental health and well-being. And so it's important to really consider that whenever you're thinking about interventions, and in particular prevention, and being able to really address people's developmental needs so that they develop, you know, the most healthily that they can under those circumstances. Now, in terms of how we assess that, in different cultures is another question, but I think it's a very important thing to consider.
Jump on and steal Rodrigo's microphone. So I'm Peter Donnelly from the University of St Andrews in Scotland. I can't resist throwing a pebble in the water here just to see where the ripples go. In fact, it's a really big rock. I think we're having quite a surreal conversation. I mean, what I heard speakers say, for example, was there's a 60% fall over 10 years in intimate partner violence in both the UK and the US, which we can't explain. And a fair summary of the very nice talk that was given would be that actually none of the stuff we're doing works. So there's clearly a disconnect between these really huge secular trends and the stuff that we're actually doing. Similarly with suicide, you know, you pointed out very honestly that there was a threefold increase in, I think, Korea and a 50% fall in China without any good explanation. You speculated, we could all join you in that speculation. My point is this: I think we've been seduced by the methodology of the randomized controlled trial. RCTs were introduced for a good reason for a specific thing. It's a great way of working out whether that new antibiotic is actually any better than the existing antibiotic. There are some public health interventions where it can play an important role. But we've been seduced into thinking that this is the only way in which we can look at some of these terribly important public health interventions and public health trends and phenomena. And I think we somehow need to find a way of stepping back from that and actually being able to look at the bigger picture as well as finding a way to evaluate the interventions.
Well, I think you summed up the presentation well. But, and if you had gotten the 40-minute presentation, which you almost got, there would have been a little bit more. You know, I've looked at these graphs for some time, and I've been interested in fact, I gave, a decade ago, I gave, in a similar panel, an entire review on prevention of intimate partner violence. And today I focus on intervention, so things about how to reduce recidivism and re-victimization. And before I had focused on prevention or to stop people onset. So I've thought a lot about why that graph's gone down a lot, given that I know I've done a lot of research in the last 25 years that doesn't show that anything we do. So Amanda and I have talked a lot about this, especially in the last 72 hours, trying to figure out, you know, is it good government, good governance? Have we thrown so much at the thing that the randomized clinical trials can't detect it? But we are doing a whole lot of stuff in a whole lot of different places. So it's more, you know, it's not necessarily the politically right word. So it's more government, but we're also doing better governance. So we have better decision-making around this, when to arrest and not arrest, across the whole gamut, when to treat and when not to treat. So we've gotten better at some of these things. My sense is, if I look at that graph and you had to ask me to explain it, our intervention programs have done not a very good job at deterrence, specific deterrence, and maybe the reduction is because of general deterrence. The rest of us, people have gotten the message. They've either seen people get arrested, they know people got arrested, they see it in the classrooms, they hear it. As we heard, you know, Jim mentioned, there's prevention programs in schools that are delivering. Now, I can tell you 10 years ago when I did a very comprehensive review of IPV prevention, in 2003, I didn't have much positive things to report either. I know there's been some further development by CDC funding that has shown better things. But my sense of the general deterrent effect of a lot of these specific treatment programs may have been done a lot to explain that reduction. At least that's my hypothesis. It's better, and maybe in the next time I come back, I'll have a better answer like that. Excuse me? Right, all the things we look at as specific deterrence, tracking the same person who's been sanctioned. What we haven't done, although there has one study out of Harvard that I would not necessarily claim to be an accurate representation of the world, thinks that actually arrest has led to more violence, arrest policies, one study, but I think there's a lot of other work that's been done that shows counter to that. I didn't report that here today because it wasn't interventions, those were prevention programs. But I think could be a lot to explain the degree.
I don't think the problem is RCTs. I think the problem is that our theoretical models aren't kind of capturing the variance and the context variables that are affecting these phenomena. And the interventions we're having are working on the margins. You know, I think there are huge social trends for suicide that are affecting suicide rates that we as researchers have very little power over. We can kind of change the inflection of the curve, but I don't think we can get zero suicide ain't going to happen ever. And we can kind of, our ability to influence change is limited, and we have to accept that. And it's often overridden by other social factors that are well beyond our control as researchers.
May I? Okay, so I also had a 40-minute presentation, and one thing that I took out was that there are different typologies of youth violence. And so some of you may have heard that there is some life course persistent offending, some adolescence limited offending, as well as some late onset offending. So I think when you look at these general trends, it sort of masks some of the noise that's going on and some of these trajectories that are really distinct within these different patterns of violence. And so I think the implications of that is that the intervention or prevention approaches based on those typologies are going to be qualitatively different. And I think that there's some of this in the IPV literature in terms of there are different types of intimate partner violence, and some are really situational specific. And so, you know, what you do to intervene in those cases is very different than those that are more persistent and based on this pattern of control. And so I think some of these trends are really masking these these qualitative differences between the groups.
Thank you very much. I'm going to comment as well, just to confuse things further on that one. I don't think we can use the excuse that these are social trends. Governments and big companies and a whole range of other people, who are the people that we advise using evidence, influence social trends. And if part of what's happening is social trends, then we should be understanding those and look at what changes them. And to say that they're too big, in my opinion, isn't the right answer. If they're the things which are impacting, and I mean, to go back to the graph before, if the graph is going down and the previous part of the graph shows that there wasn't an evidence base informing that, then that should concern us all about the impact and the value of the things that we're producing. So,
Hi, Dina Della Georges from UN Women. And my question is for Chris, or rather, perhaps you could clarify a little bit. When we're talking about prevalence or incidence, and unlike other criminal justice issues, the way that in the violence against women world we talk about these things is a bit different. Where prevalence is the rate at which women and girls within a certain population will have experienced some form of violence in either her lifetime or past 12 months. And incidence being that person who's experienced abuse, the repeat abuse. And I think it's important for the conversation that we're having, because what we're looking at, not just in the United States but in other places in the world, is that a whole host of resources, the few that exist, go into response and into providing services for survivors of abuse. When we want to look at prevalence and stopping abuse from happening in the first place, there's an emerging now area of promising practice where we have a whole host of new interventions that need to be taking place that are completely underfunded. So I was wondering if maybe you could speak a little bit to those issues.
Well, again, what I was focusing on was intervention. So things that tries to reduce, in the terminology you reduce, to reduce incidence or the frequency of violence. If we were to, in criminology, we talk about prevalence, and that's yes or no, have you ever experienced, and frequency is how many times. And so most of the research has either tried to, as we talked about, trying to reduce the frequency of violence over time that someone might report. I think the graph also to look at is the age graph that I put up, which showed that there is something going on among young kids as we've gone over the cohorts over the last 20 years. The rate has substantially dropped of prevalence of intimate partner violence among young folks to almost the point that it matches older folks, which is always, and that's, in criminology, this is, and we just realized this is something we've never seen before. The age crime curve has vanished, essentially between the last 20 years. And so what's gone on among young people to stop them from, as you described, onsetting or becoming more, and that's what we need to figure out is what's gone on and to bring that curve among young people down. And that's in my belief, that's probably prevention programs, not intervention programs.
Mary Ellsberg from George Washington University. I was really thinking about the same issue, the disconnect between the first graphs and then, why things went down. And if it were just a natural phenomenon, you'd expect to see it in other countries. And I just don't think we see, outside of the tendencies in the United States and UK, I don't think we're seeing a reduction in most other places in low-income settings in intimate partner violence. And so I was just wondering if you've looked at issues of acceptability of violence, of social norms. I mean, we think that in low-income settings, that's driving a lot of the high prevalence, and maybe that's what's driving the decline here.
I haven't, and I don't know if anybody has tracked social norms about domestic violence over time. Mm-hmm. With CDC support, we did a large survey of 15,000 people about 7 years ago. Mm-hmm. And we asked a random sample of people, and almost everybody, male and female, rejected intimate partner violence. Most people thought people should be arrested. This was the U.S. So in the early 2000s, there was a lot of rejection of intimate partner violence, almost universally in the data set. I would love to be able to try to do that kind of work. We essentially lack the data and access to be able to do some of this stuff in other places.
3 questions. Then we'll finish, and I just apologize. I mean, I said 10 minutes questions. Atrocious. Let me apologize for that. We'll do these 3, and then I promise. Summarizing.
I'm Galina Udovich from the American College of Obstetricians and Gynecologists. This question is specifically for Chris, and also specifically for the rates of police intervention and how that affects victimization. In the District of Columbia and a number of other states, there's mandatory arrest laws. So domestic violence is reported, the police report to the scene. somebody must be arrested or a warrant has to be issued for arrest. This has, I don't know how that affects the rates in the studies and if those were controlled as separate studies, and if you could speak to that. And also when an incomplete analysis of the crime scene is completed, and there it often results in dual arrests and crisscross arrests when the aggressor versus the victim are not properly identified, and if that was also calculated in any of the studies.
So the experiments that I talked about for arrest all predated almost in every place mandatory arrest. They are actually the evidence that formed the foundation in the United States to have those laws in place. And so it's all sort of predates that. And there were a couple PIs at the time in the mid-'80s who wanted to do those experiments in places like San Francisco and other places, but couldn't because the prosecutors or the attorney generals wouldn't allow them to because they were going to do the mandatory arrest. So the states that actually ended up in were places that still hadn't implemented mandatory arrest by the late 80s. So we didn't have, those experiments didn't necessarily have to account for the presence of laws or not, because it literally, if we talk about the difficulty of doing randomized clinical studies, if we think about it, in the mid-'80s, we were randomly allocating who got arrested and who didn't. The police were flipping a coin. So if you can get police to flip a coin to do randomized experiments, we can do a lot. Yeah.
I can just say I'm very glad that they're not serving insecticide outside there, Michael. Here's the scenario that I get, and I want you to, all the panel to comment on this. So we find that in each area of violence, we have a really terrible problem. We have a terrible problem with child abuse and neglect. We have a terrible problem with youth violence, a terrible problem with interpartner violence and suicide. And so then people come along and say, well, okay, we have something that works. And we're going to go out there and we're going to do it. And then the researchers come along and they say, whoa, not so fast. The wonderful thing that you have that works doesn't. It doesn't work. And so we're left with this problem where we don't know whether the people haven't designed the right interventions because we don't understand the theoretical model or because we don't understand the ecological model and framework well enough. But it may be that we haven't devised the right interventions, or it may be that the evaluators haven't done the right studies. They don't have enough, they're not well enough designed, they're not testing the right thing. But we're left with this situation where we don't really have things that work for a terrible problem. Now shift your frame to low and middle income countries. We've said all the research has been done in these high income countries that have really good interventions and really good evaluators, and we're left there with this situation. What do we do to avoid the same situation repeating itself as we move towards the low and middle income countries where 95 or 90% of the problem exists? How do we avoid staying in the same situation, and how do we avoid a repeat?
You got to have situation analysis of the available resources in the community, and because they can't repeat they don't have the resources to do all these evaluation studies, but they can select and cherry pick. But to cherry pick which ones, you need to have a process of saying who are the actors, what are the outcomes we're looking for, and what are the potential resources available to implement any particular intervention, and to cherry pick which ones kind of make the best fit, and then do a more detailed, a slightly different type of evaluation of it.
I was in Namibia in fall, and they approached me to ask me what would work to reduce intimate partner violence if they intervened. And so I didn't have a lot to say, obviously. And I asked them what were the 3 things that they think should work. They named all 3 things we've never tried and didn't even consider trying. I would first ask them what they think might work, and then work with them to try to test them, then to try to move what we've not done very well here. But I would begin with them, asking them.
Yeah, I think it's a great point to ask them. But I also wanted to say that there is a solid evidence base for youth violence prevention. And I mentioned that we have it at the individual, family, relational level, and there are some gaps in other areas. But I think a lot of these questions really lie in the gaps that I outlined and I talked about. You know, issues around cultural adaptations, issues about, you know, whether people even recognize adolescence as, you know, a distinct period of the life course. And if they don't, how do you translate these interventions so that they are applicable in these other contexts? And so we can lay out a whole research agenda about how to translate and how to work with other countries and other communities about the best way to meet their needs. And so it really has to be context specific.
I would also say in the child maltreatment area, I gave you lots of interventions that are promising. They need to be replicated. So that's important. But the other thing is, I think in the area of what's now called prevention science, we've learned a lot about involving people who are going to be receiving the intervention, et cetera, from the beginning. Do the pilot work, use mixed methods, qualitative and quantitative. It's not one versus the other, it's what's the best method to answer the question. And I also think, quite frankly, that high-income countries have to step up to the plate in putting resources into funding these kinds of initiatives in low and middle-income countries. Public Health Agency of Canada is putting funds out there to evaluate things elsewhere, and I think that we, in turn, in high-income countries will benefit from that, and I think we have to hold our governments accountable to do that.
And if I'm allowed to comment on that, I think the first part is, I think we're too critical of the things that we assess ourselves. I think sometimes, particularly from a public health perspective, the bar's set too high. And even compared to other disciplines, when you look at some other areas, the evidence isn't quite as great as people suggest. I think they're just not always as openly critical of their own evidence base. And then, even where we haven't got good evidence, I think we've got a theoretical basis from what we've looked at. And then we should use that to try and help people who explain to us what their assets are in low and middle income countries to turn those into the right sorts of answers. So that combination of a general understanding plus what assets they can bring to bear should provide some new solutions. Well, exactly like I said, we finished at 5 o'clock. And I'd like to now pass over for the summary of the day one to Jacqueline Lloyd from the National Institute of Drug Abuse. Thank you. Oh, first, can I thank all the speakers as well, please?